Hi friends, Pradeep Pendyala, Professor of Anesthesiology at Asram Medical College, Eluru City of Andhra Pradesh, India. Friends, today I am going to talk about anesthesia in high altitude. By the way, I have worked in Indian Army for more than 33 years and I have served in high altitude area for more than 3 years. So I have enough experience about anesthesia in high altitude. So let me share some of my experiences and little bit of information here and there. So let's start. Friends, halothane is satisfactory agent for use in high altitude. Surprising, but that's a fact. It permits the use of higher concentrations of oxygen and provide rapid induction with a rapid recovery. Assisted or controlled ventilation is required even these agents to prevent muscle fatigue and avoid hypoxia. The disadvantages of halothane are obvious. It causes bradycardia and hypotension. By the way, dissociative analgesia with ketamine will definitely work wonderful. Supplemental oxygen may not be available in some of the higher altitude location. In that case, ketamine would be very, very helpful. Ketamine anesthesia is a safe anesthesia agent used at high altitude. Talking about spinal anesthesia, better to be avoided wherever possible in high altitude. The incidence of post-operative headache is too high. Possibly it may result from a decrease in alveolar ventilation and hypoxia or from poor hydration. So this would be my suggestion for pre-medication for general anesthesia. You should always remember that opioids depress tachycardia and hyperapnea. That normally occurs in response to hypoxemia. So that would be disadvantageous. So better avoid opioids in pre-medication. Benzodiazepines, barbiturates and NSAIDs can also be used definitely to allay the anxiety and to reduce pain. Injection atropine and glycopyrrolate you can definitely use. Regarding muscle relaxants, short-acting muscle relaxants are preferable. Succinylcholine definitely can be used safely for intubation. Long-acting muscle relaxants like pancuronium, pavilon, vecuronium, atacurium can be used, but you have to take into consideration the duration of muscle relaxants. Assisted and controlled ventilation should be continued till the patient regains consciousness and adequate respiration takes place. Vaporizers are very interesting. The saturated vapor pressure of any inhalational anesthetic drugs does not change with change of ambient pressure, but changes with temperature. At any settings, the delivered percentage of inhalational agents will increase with altitude. However, its partial pressure will remain constant. Flowtech and Draeger vaporizers exhibit variation, but changes in the splitting ratio is slight. So, in the clinical effect with any given dial setting, anesthetic will be delivered at constant potency regardless of altitude. Friends, regarding oxygen, a high concentration of oxygen should be given at least 40% higher than at the sea level. So take care. Regarding nitrous oxide, as barometric pressure is reduced, fixed concentration of inhaled anesthetics will have less potency at high altitude. So it is of little use as an anesthetic. Regarding ether, with equivalent concentrations at sea level, ether induction at high altitude is slow and maintenance also requires higher concentrations. Friends, regarding high altitude anesthesia, there are many things which has to be considered, especially the changes in the serious respiratory, and the anesthesiologist working at increased altitude must consider the physical and physiological effects of low barometric pressures, decreased oxygen tension, and physiological changes of acclimatized and unacclimatized residents or the patient. Also to be considered are the changes that occur with volatile agents, adjunct drugs, and anesthetic equipment. The anesthesiologist should avoid drugs that have a prolonged depressing effect. A smooth, rapid induction with tracheal intubation is definitely recommended. Agents such as halothane is used primarily because it allows increased oxygen concentration. Short-acting muscle relaxants are used to control alveolar ventilation, and thus they avoid hypoxia. Spinal anesthesia, as I had mentioned, is thought to decrease alveolar ventilation, resulting in hypoxia, so better to avoid. This decrease is thought to increase the incidence of post-spinal headache, and preferably spinal is avoided in high altitude. Regarding other factors like what are the changes in respiratory and body temperature, those things has to be considered. Low ambient temperature can be encountered in high altitude, particularly when anesthesia is to be performed at field condition. Hypothermia is defined as core body temperature less than 35 degrees centigrade. Once body temperature falls below 35 degrees centigrade, the ability of hypothalamus, the temperature regulation center, is lost. Definitely. And the temperature regulation center is lost due to the depression of production of chemical heat by the cells concerned. As temperature decreases, there is fall of blood pressure, although initially there is a rise in BP due to release of catecholamine. There is marked irritability of atrioventricular bundle node, leading to atrial and ventricular fibrillation. Regarding volume replacement, you must know whenever indicated, it can be performed by using intravenous crystalloids, colloids, blood, or plasma. However, all intravenous fluids and blood should be warm to body temperature before transfusion, and great care should be taken not to overload the patient with fluid in view of risk of developing pulmonary edema. There is so much more to be talked about this interesting topic. Hope I have spoken few interesting topics about the anesthetic management in high altitude and you liked it. Thanks for patient listening. Bye bye, take care. Until next time, bye bye, take care.